Well, hello everyone, and welcome to this BTOG webinar. It's been ages since we've been with you online, and I'm delighted to join you all for this ASCO 2023 and AACR 2023 update. We've had some amazing data presented at these two really important meetings, data which will undoubtedly impact your practice either tomorrow or in the near future. And so let's deep dive into this. We're going to be online for about an hour and a quarter, going into the data. And actually with this type of meeting, what we're really keen to have is your questions. So do make sure during the presentations that you type in your questions into Slido. So welcome to the meeting, and on behalf of BTOG, it's absolutely great to be with you. We're going to have excellent discussions. As you know, Dawn and Gina, who are part of the executive team, are always available for you if you need anything in terms of BTOG's activities. A bit of housekeeping. Do make sure that you do type your questions in the control panel. In fact, your questions are really critical to the success. I want you to keep our panelists on their toes. I want you to ask questions to challenge them if you don't agree with their interpretation, and ask how this is going to impact on practice. We will send you an email for your feedback, and that's going to be linked to your certificate of attendance, and we are aiming for this to be accredited by the RCP for CPD, and it is available online as well for 4 weeks after the event date until the 10th of July for you to claim your CPD. So here's the agenda. First off, we're going to be have a presentation by my colleague, Dr. Tom Newsom-Davis, who's Vice Chair of the BTOG Steering Committee and Consultant Medical Oncologist at the Chelsea and Westminster Hospital. And he's actually just going to give us an update on everything to do with EGFR mutant lung cancer. There's so much to deep dive into. We'll then be joined by Yvonne Summers, who's Medical Oncologist at the Christie, who's going to talk about non-EGFR driven tumours and a few bits and bobs elsewhere. And then Riaz Shah, who's Medical Oncologist at the Kent Oncology Centre, is going to update us on all that's happening in meso and neoadjuvant SAC. And boy, there's a lot going on. We're going to actually take 5 minutes of questions after each presentation. So please do keep your questions coming in throughout the presentation so we can take your questions at the end of each individual's talk. So without further ado, let's crack on with our first presenter, Tom Newsom-Davis. Tom is going to speak to us about the update at ASCO and AACR about everything EGFR mutant. So remember, do go to Slido on your panel and give your make sure you type in your questions, which we can then take at the end of the presentation. So Tom, are you there? Over to you to give us your update on EGFR mutant disease. Reveal yourself and take it away.
Thank you, Sanjay. I would reveal myself, but my computer says I can't start my video because the host has stopped it. So if the host could unstop it, that would be super.
Great.
There we go.
There we go. Well done. All right, over to you, Tom.
Thank you, Sanjay, and thank you very much for asking me to be part of this. I'm going for the informal shirt-only look because in my hospital, it's about 120 degrees. So look a bit hot and flustered. That's the reason. Actually, everything I'm going to talk to you about is from ASCO. There weren't actually any particular ones from AACR about EGFR mutated lung cancer, but we've got more than enough to be getting on with. Here are my disclosures. So I'm going to tell you roughly 3 aspects of EGFR from ASCO, which is going to impact today and probably next year on your treatments. Number 1 is adjuvant osimertinib. Now, you're probably using this already, and if you're not, probably should be. And we now have overall survival data, the holy grail. This made the Guardian on newspaper. What could be a higher accolade than that? Number 2, what do you do after osimertinib? Still a very difficult area. And I've got some data on chemoimmunotherapy, what to do with MET amplifications, and these rare additional mutations. And we might have something up our sleeve for that. And then finally, I'm going to talk to you about the rare mutations. In fact, exon 20 insertion mutations, which we're picking up more and more now that I hope we're not using PCR for our molecular analysis. Instead, we're using NGS. So we're going to kick off with adjuvant treatment. So ADAURA-2 was in the plenary session, the absolute high point, the Manchester City of ASCO. And what was presented here was the overall survival data. In case you've been under a rock for the past few years, ADAURA is a big phase 3 study which took patients with resectable lung cancer, was removed at surgery. They got chemotherapy if that was felt to be appropriate by the treating physician. Then they were randomized, you can see in the blue and the yellow box, to osimertinib adjuvantly for 3 years or placebo. Now, actually, you see in my arrow on the top right-hand side, it says this was unblinded early due to IDMC recommendation. In other words, the IDMC, the Independent Data Monitoring Committee, saw that the data was very strongly positive and therefore unblinded it early. And that's important when we look at the outcomes. The other thing I'd like to point out with my bottom arrow there is the primary endpoint was disease-free survival. Overall survival, which I'm going to show you, was a key secondary endpoint, but we should remember that disease-free survival was the primary endpoint. So you may be thinking, hang on, Tom, I've heard about this data already. And you're absolutely right, you have. We've seen the disease-free survival data dripped out over a couple of years, originally in the New England Journal of Medicine in 2020, and then we had some updates last year. And you can see on the left-hand graph there, you have the original disease-free survival data with very big separation of the curves and this hazard ratio, the bottom left-hand side there, of 0.2, which is incredibly high. On the right, we saw an update which came out in ESMO in the autumn of last year, showing, as you can see, more maturity of the data, and those curves apart, but maybe drifting together. Now, I want you to look at 36 months along that graph, and you can see at 36 months, those curves are beginning to come together. And we should remind ourselves that osimertinib was given for 36 months. And so the question people have asked is, was osimertinib actually curing anyone or just delaying relapse? So the overall survival data was really important. This is the data. So overall survival, as you can see on the right-hand side, the hazard ratio is 0.49, which is an extremely impressive, more than 50% reduction, with a highly significant p-value, as you can see. And you want to look at the landmarks. I find that quite useful. Look at 60 months, which of course is 5 years. You can see it's just over a 10% improvement in overall survival, 12% in this patient group, which was the intention to treat population. So you may look at those and go, well, that's not a huge difference in terms of overall survival looking at the graphs, but actually, if you look at the hazard ratio, that is fairly impressive. So what do we know about subgroups? Well, we'll run our eyes down here. We might see that in terms of gender, men do a little bit less well than women. Age and smoking history don't seem to make much difference. But I'd like to draw attention to the two bits with the red triangle. And you can see that Asian patients do less well than non-Asian patients. And patients with an L858R mutation do less well than patients with an exon 19 deletion. And we've seen this trend before. We've seen this trend with osimertinib when it's used in the first-line setting, in the metastatic setting, for example. So that's just something for us to keep an eye on. I'll also ask you to look at the bottom line where it says adjuvant chemotherapy. And you can see that whether you got adjuvant chemo or not didn't seem to make a huge amount of difference. So this is a contentious study. And it's a contentious study, and lots of people in Twitter are getting very exercised about this, because there's one aspect of the study which is really important to focus on. And that is what happened to people after their cancer came back. So the area in the red box is probably the most important bit. So what I'd like you to look at is in that red box, you can see on the top line of it, it said patients who received subsequent anti-cancer therapy. Now, of course, the patients with the osimertinib, fewer of them got anti-cancer therapy. We'd expect that because it's working. But if you look at the placebo, it's 54%. And I'd like you to then run down your eye to where it says osimertinib, and it says 43. So what that means is, in the placebo arm, these were patients who had surgery, they may or may not have had chemo, and then their cancer came back and they needed another TKI, or they needed a TKI, only 43% got osimertinib. So the criticism of this study is that not enough people had access to osimertinib when their cancer came back. And if you didn't have access to the drug, maybe it isn't a fair trial, because actually what they really should have got when their cancer came back, they all should have got osimertinib. Now, why didn't they? Well, it's because the drug wasn't available in those countries at that time. So lots and lots of chat, lots of people getting angry. What's my thoughts on ADAURA? Well, my first thought is it's positive for overall survival. My second thought is, yes, I think there is some compromise with only 43% of patients getting osimertinib in the control arm, but I don't think it invalidates that big hazard ratio of 0.49. There's a more philosophical point, which is, are they cured or have we just delayed relapse? We know at 5 years, 12% more patients are alive than who took osimertinib than weren't. And we use that number, that 5-year survival, we happily use that with adjuvant cisplatin for years and years and years. But I think there is a philosophical question as to whether we have cured them or we're just delaying relapse. And there is a fact I've noticed in my adjuvant patients, which is 3 years of osimertinib is challenging. The discontinuation rates are quite high. They're higher than you get in the metastatic setting. And we do have some unanswered questions. We don't know the optimal duration of osimertinib. Is it 3 years? Is it 5 years? Is it forever? We don't know that. We don't really know who needs chemo. Remember, chemo was optional here. And we don't know for the other mutations, the non-exon 19 and L858R ones, we don't know whether osimertinib has a role in those. And I think those unanswered questions will be the subject of ongoing discussions for a long time. So that's adjuvant. What about people who have metastatic disease? You've used your osimertinib as the first treatment. What are you going to use next? Well, we know that resistance to osimertinib is quite disparate. There's not just one process going on you can jump onto, give them another TKI. And this is a slide that's been doing the rounds for a while. And look at the bottom left-hand arrow. It's from ESMO in 2018. So 5 years ago, we were talking about this. And the truth is, we haven't made much progress in coming up with a defined answer. On the top are a number of processes of the cell surface, which drive resistance to osimertinib. On the left, you can see you have secondary mutations of the EGFR mutation, for example, C797X. You can have HER2 amplifications, running your eye along there. And on the right, you can have MET amplifications as well. And there's some other processes within the cell under the line. You also see BRAF mutations, KRAS mutations, PIK3CA mutations. There's a whole range of those. And if you look at the various percentages, there's no one real dominant process. So we've had to look at a number of different processes to try to work out what to tackle. In truth, the thing we really do, most likely in clinic, behind my door here every week, is to give chemotherapy. And we tend to give pemetrexed and platinum-based chemo, don't we? That's what we do. And the question we've been asking is, what happens if you add immunotherapy to that? I suspect most of you listening will be giving PEM platinum as your first-line treatment for non-EGFR mutated lung cancers, or non-mutation-driven lung cancers. But we don't tend to use that in people after osimertinib. What happens if you try? So Keynote 789 was looking exactly that. They'd all had TKIs, either first-line Osi or first-line first or second generation, and then osimertinib afterwards if it was appropriate. And then they were randomized at that stage to PEM platinum or PEM platinum with pembrolizumab, and that went up for a maximum of 2 years. And yes, you could cross over to pembrolizumab if you needed. Your primary endpoint was progression-free survival and overall survival. I don't tend to mention stats very much when we come to presentations. I don't understand them, but I would like you to look on the right-hand side here where the red arrow is saying that for this study, statistical significance was below 0.117. Okay, not 0.5, but 0.117. What we found was no significant improvement in progression-free survival. Yes, the hazard ratio top right-hand side is 0.8, and yes, that's a low p-value, but it's above 0.117, so non-significant improvement in progression-free survival and a non-significant improvement in overall survival as well. So there is no justification in my book to be adding pembrolizumab to PEM-carbo in your relapsed osimertinib patients. The next thing we've looked at is MET overexpression. I mentioned to you that MET amplification is, sorry, not overexpression, amplification is one of the key drivers that we see. And this is a study looking at adding tepotinib to osimertinib. Now, you may say, I know tepotinib, and you're absolutely right. You do know tepotinib. That's a drug which is currently available for MET exon 14 skipping mutations. But here it's being added to osimertinib in a situation where you know there's MET amplification, either diagnosed through tissue biopsy or through liquid biopsy. And this is from the tissue biopsy. Look on the right-hand side, that's a waterfall plot showing there's activity. And if you look at the graph on the table on the left, you'll see the second row down, it says overall response rate of 43%, which I think is a very respectable overall response rate. The duration of response, the line below, is just under 10 months. And with a median progression-free survival, probably slightly disappointing at just over 5 months. And we don't know yet what the median overall survival is. So I think this has activity. And whether it's a tissue biopsy or, next slide, liquid biopsy, we're seeing very similar activity. And that's helpful because we know that actually getting tissue biopsy when a patient relapses on a TKI is not always straightforward. It can be very low volume disease. And yes, you can diagnose this at liquid biopsy, and there is activity. Quite well tolerated. What we're seeing is the classic side effects we'd expect with osimertinib, and with some additional ones such as peripheral edema that we're noticing with tepotinib, but a tolerated process, and concerns about pneumonitis, not particularly founded, seems to have quite a low rate of pneumonitis. So I think this is an interesting development. And finally, we learned about these rare mutations, the new EGFR mutations. This was a phase 1 study which came out of our colleagues, and in particular Anna Mintram, who is a friend of BTOG and a general supporter of all our work, looking at Blue 945, new drug, and also Blue 945 combined with osimertinib. Well, why was it combined with osimertinib? Because by itself, it was quite disappointing. These are patients who have had and exhausted their osimertinib options. And there is a bit of a response rate there, but you can see on the red triangle, unfortunately, that duration of benefit is pretty limited. So probably we're more excited about this, which is combining Blue 945 with osimertinib. We're getting a more interesting response rate there. And if you look at you cast your eyes at the bottom where all the X's are, you can see the very bottom row of that. Patients with a C797S, they're responding largely very well to this combination. So I think this is something to be keeping an eye on as being able to target new mutations coming through and maybe adding in Blue 945. Not without its problems, not without its side effects. There's a little bit of hepatotoxicity, but actually largely well tolerated. And I think is going to be a realistic prospect in terms of a combination we can use with a safety signal that's acceptable. So what's my take on post-osimertinib? It's a really challenging space, isn't it? There hasn't been one answer to everything. I don't think there's a role for adding pembrolizumab to pemplatinum. I'd be interested to know whether anti-angiogenic drugs add anything. You might remember the Empower 150 study, which showed some evidence of benefit, although the overall survival benefit got washed out after 5 years. But keep your eye on a study called Orient 31. We're looking for the overall survival of that, which may come out in the near future. I think tepotinib and osimertinib for your MET amplification are interesting. I think they're active. Both drugs are licensed in lung cancer, although not quite to tepotinib in this setting. But its challenges is to define what MET amplification is. Blue 945, disappointing alone, but better with osimertinib. And that's one to watch. And the last thing I'm going to tell you about is exon 20 insertion mutations. Important to look for these. PCR-based assays miss them, so make sure you're using an NGS-based assay. And we have 2 drugs available for EGFR exon 20 insertions. Mobocertinib on the left, available NHS. Amivantamab on the right, not available NHS at the moment. Run your eyes along the overall survival. You'll see that's very similar, perhaps a little bit higher with amivantamab. Run your eye along the progression-free survival, very similar, and overall survival, very similar. But actually, I think probably slightly disappointing, if we're being honest, compared to what we see in the classic common mutations. So there's a lot of interest in new drugs that might cause this, might treat this. The other issue with mobocertinib is it causes diarrhea, quite significant diarrhea. And one of the issues with amivantamab is infusion-related reactions, which can be quite problematic. And those initial first infusions are quite heavy on chemotherapy day unit time and can be quite intimidating for patients and chemotherapy nurses alike. So we've got a new drug called sunvozertinib, which there's a phase 2 study of, looking at patients as a first-line setting, second to third-line setting of this agent. So it's seeing activity. and looking including intracranial disease activity as well. And what we can see here is very good response. This is a waterfall plot, so all the lines below the line are response, and it's been divided according to the particular type of EGFR exon 20 insertion mutation they have. And you can see the bottom, so the second line from the top, we can see the presence of baseline brain metastases picked out with the blue boxes, and you can see there's activity both in patients with brain mets and without, which is of course very encouraging. The average duration of treatment is about 7 months, and the longest duration is just over 18 months. And so I think this is a drug with activity. Side effects seem to be manageable, with increased serum phosphokinase, creatine phosphokinase, sorry, as probably the commonest, along with diarrhea. But a manageable profile and less of these severe GI toxicities that we see with some other drugs in this area, although not without its side effects. So my thoughts on this, as my penultimate slide, is room for improvement with current agents, definitely. That I think sunvozertinib is active. There's intracranial activity of just under 50%. There's an ongoing phase 3 study of first-line sunvo plus chemotherapy. I'd be interested to see that. And I see this as a challenger to the status quo that is currently MOBO or amivantamab. Look at a study by, again, Anna Mincham on subcutaneous amivantamab. Looks like it has the same activity as amivantamab, but without those problematic intravenous side effects. And I'd be interested to see if that might be on its way as well. That's also at ASCO, and that was a Paloma study. So there you go. Those are my 3. Adjuvant osimertinib, overall survival I've shown you, post first-line osimertinib, chemoimmunotherapy, MET and C797S among some other mutations, and the rare mutation sunvo coming along with the exon 20 insertions. And that's me. Thank you very much.
Tom, thanks very much for that superb and very clear update. So folk online, if you've got any questions, do type them into Slido, and we can take them for Tom. But I'm going to kick off with Tom. So ADAURA, clearly, I mean, a massive impact with disease-free survival. Everybody, has pretty much wanted to use it as standard of care. And I think many people are using it as standard of care. And to me, I think the overall survival just reinforces that. And it's wonderful to see overall survival. But the key question is, what about adjuvant chemotherapy? So what are your thoughts with this? Should EGFR mutant patients, if eligible for adjuvant chemo, get adjuvant chemo?
Yeah, I think it's a very interesting question. There's quite a variation in the study according to who gave it and who didn't. You'll see that the hazard ratios for overall survival didn't differ according to that. So we're not getting a strong signal that you shouldn't be giving adjuvant chemotherapy. My take and my personal approach is that if someone is suitable for adjuvant chemotherapy based on our standard criteria, tumor more than 4 centimeters, node positive, they are good performance status. I personally prefer people to receive adjuvant chemotherapy who are younger. I find it more difficult, and I think there's much less evidence in patients over the age of 70. But if they're good performance status, younger group, and they fall into that group, I would still give adjuvant chemotherapy. I do not see osimertinib as a replacement for that, and that remains the case. Of course, if someone said they don't want it, then that's fine. But it's still, to me, the first bit of what you do, and then your osimertinib comes in afterwards.
So I totally agree with you. I mean, the study wasn't designed really to investigate the role of chemo. So, my view on it is chemo is still standard where indicated, and the question is really whether you add in osimertinib on top. And I think that makes biological sense, right? Because these are heterogeneous tumors, and many tumors are driven by the branch mutations that occur on heterogeneity. And you're quite right, it's not as easy in the adjuvant setting, isn't it? The dose reduction rate was almost double in ADAURA as we've seen with FLAURA. And then in the stage 3 setting, I mean, you didn't mention this, but we've got the LAURA data coming out at some point in the next 12 months or so, which is looking at osimertinib consolidating radical stage 3 non-small cell lung cancer. So we very much look forward to that. And then you talked about the ongoing synergy with tepotinib and osimertinib with MET amplification. So my understanding is that we do have access to tepotinib in the UK for patients who progress on osimertinib with MET amplification via the company on the named patient. Is it possible to look for MET amplification in the NHS at the moment? Tom, what's your experience and the Genomic Medicine Service view on that?
Yeah, we get our genomic service from a place called the Royal Marsden Hospital. I don't know if you've heard of it. It's a bit of a shoestring effort, but they do a decent job sometimes. Yes, it is, and I think knowing that availability of the drug on a named patient basis is really important. I've always thought this tepotinib Aussie data has been a little bit undersold. It came out in ESMO last year. They only had response rate data, didn't have survival data. But they're two drugs which are literally in your pharmacy. I think that's an acceptable response rate. I would love it to be a bit higher, but it's very acceptable. If you do respond, you respond quite well. Yes, it is available. You can see MET amplification. What I would do, if you're not sure how to look for it or where it is, or if it's not coming to you in the right way, I would recommend speaking to your molecular pathologist, because I bet they know the data, and I bet they can tell you exactly what you're looking for. And if it's not immediately apparent on your report, then ask for it. I think it's a reason to look for biopsy. I think it's a reason for us to rebiopsy our patients, because I think if you can put them onto this, it's about 15% allegedly MET amplification rates, and you can push off chemo a little bit longer. I think that's a great thing.
I agree. Dual targeted oral therapy. I mean, what's there not to like, right? So, I think that really is a great option for our patients. You've got to look for it, and if you don't look, you don't find. I mean, you've got to have biopsiable disease, which is the challenge, right? So one question that's come in is being very cynical about the control arm of Ardura, right? So is the fact that we've got an overall survival advantage here just because we had an inferior performing control arm, one where not everybody got osimertinib? My personal view on this is actually that's the real world, right? People don't get what they're allocated to get because stuff happens. People have brain metastases deteriorate, people have pulmonary emboli deteriorate. So it is an intention to treat analysis. And if we're waiting for global world change, we're going to be waiting for years to implement therapy and trials to read out. But Tom, let's take your view on it. Do you think it's a cynical ploy by the sponsor, or is this valid outcome?
I don't think it's a cynical ploy by the sponsor. No, I think that there is an issue with access to osimertinib. It's a very expensive drug, and countries that can't afford it can't afford it. And I think we should always drive for equity of access to drugs throughout the world. The study was started a while ago, and not every country then by any means had first-line osimertinib, and not every country still has first-line osimertinib, I'm afraid to say. I think in the ideal world, you would absolutely have a situation where everyone could have had access to it. I think it does have an impact on the results. I think when you look at that overall survival hazard ratio, I think you've got to interpret that with the knowledge that only 43% of people got osimertinib in the placebo arm when they relapsed. As you say, it was never going to be 100%. Life isn't like that. But I think it does make us reflect the overall survival benefit. But I still think it's a very big overall survival benefit. And if you compare that to what we have been based on platinum-based chemo on for a very, very long time, I think that still remains a very strong overall survival benefit. To me, sometimes the question is, what would you do if a relative was stay? If a relative phoned up and said, look, I'm in this situation, should I have adjuvant osimertinib? I would say, yeah. Yeah, there are some caveats on the overall survival. I don't know if the true value is exactly 0.49, but I do believe there's an overall survival benefit there at 5 years.
Yeah, totally agree with much of your interpretation there. And just to flag that in the UK, we will be running the Target study, which is looking at two cohorts of adjuvant patients. One, a cohort with common mutations looking at 5 years worth of therapy, and also looking at the uncommon mutations, which are likely to be osimertinib sensitive. So hopefully we'll be able to answer some of those questions in due course. Now, Tom, one final question's come in, which is about MET amplification. So you got your osimertinib patient frontline, and they've PD'd, and you're looking for MET amplification, but you're lucky enough to access ctDNA, and the ctDNA comes back without MET amplification. Do you still give tepotinib, or do you need to biopsy, or do you go straight to chemo? how do you manage that? With ctDNA comes back no meta
Yeah,
amplification.
I suspect you will find on an inpatient basis that to have access to that drug, you would need to show amplification. And I think if you're not able to show that on the platform you're using, I think my personal approach would be to find tissue confirmation of that. I did find in the ASCO presentations the details of a liquid biopsy and the threshold I found quite difficult to see. I couldn't see very much on that. So I don't have clarity in that, but I think I'd want a piece of paper saying, yes, there's clear meta amplification, so I feel justified wheeling my topotenin about.
I think that's absolutely correct, right? You need to know whether it's on target or off target resistance. And if it's off target resistance, what is the mechanism? And, with ctDNA, the technology is not really well validated for copy number gain or true amplification identification. So yes, if you find it, brilliant. But if you don't find it, we really do need tissue. Anyway, Tom, we could go on about this for hours. Thank you very much, and fantastic work. Thank you for putting this all together at very, very short notice and hot off the press. Everybody came back from ASCO on Wednesday, and you're already in front of everybody's screen so far. So now over to Yvonne. Yvonne, you're going to speak to us about the non-oncogenic, non-EGFR drivers and a bit of odds and sods from everywhere else. So Yvonne, take it away.
Thanks, Sanjay. So I'm hoping you can hear me. There's a lot of thunder and lightning behind me here in Manchester, so hopefully it will all go according to plan. So I've got a bit of a smorgasbord of some of the other data that was presented at ASCO. So you've heard the really big data from Tom on EGFR. I'm going to be sandwiched in between Tom and Riaz talking about neoadjuvant chemoimmunotherapy, but there was some really other interesting data. So I'm going to touch for a start on non-EGF molecularly driven cancer and some of the data, particularly in brain metastasis there. Then go on to look at an example of ADCs in non-small cell lung cancer. We're going to then change tack completely and think about a radiotherapy study in intermediate-stage small cell. And then I'm going to leave you with Quirky Corner and a bit of a curiosity that was presented in one of the last sessions. So starting with molecularly driven lung cancer, we know brain metastases are such a big problem. And for patients with KRAS G12C, brain metastases are also a problem, about 10 to 20% of them at diagnosis. And the incidence of those brain metastases, of course, increases over time. And it's such a big problem because, of course, it impacts on our quality of life for patients and, of course, overall survival. So we importantly had data from CodeBreak 200. So this was the randomized trial in patients with KRAS G12C non-small cell lung cancer who'd been previously treated with chemotherapy and immunotherapy. And patients in this study were randomized to either receive docetaxel or sotorasib. And the presentation at ASCO focused on those with brain metastases and the efficacy in those groups. So you can see that on the left-hand side, 40 of the 171 patients receiving sotorasib had brain metastases, and similarly on the docetaxel, 29 of the 174 patients had brain metastases. And of those that were measurable, of course, there were slightly lower numbers. And so when we come to look at the efficacy on the top left-hand corner, you can see that in terms of progression in the CNS, patients receiving sotorasib had an 11.6-month CNS progression compared to 6 months only in those receiving docetaxel, with a significant hazard ratio. So confirming that sotorasib does indeed get into the brain. And in terms of those that had measurable disease, you can see the objective response was confirmed in about a third of patients receiving sotorasib in the brain, compared to only 15% of those receiving docetaxel. And there was concordance between the CNS response and the extracranial response. So really reassuring data for our clinical practice that sotorasib does have activity in the brain. But I would just advise, remember this was post-hoc analysis, and this was in patients who had stable treated brain metastases. And so it would be helpful for us to see the activity, perhaps in future studies of sotorasib in patients with untreated brain metastases. So sticking with the brain mets theme, what about other molecularly driven cohorts? So this was data from Trident-1, which is the phase 1/2 study of repotrectinib in ROS1 fusion non-small cell lung cancer. And in this study, you can see that the patients were a mix of either those that had been previously treated with a ROS1 TKI or those that were ROS1 TKI naive. And of the naive patients, about a quarter of them had brain metastasis at baseline, compared to about 43% of those that had had a previous TKI prior to entering into the study. And you can see on that table on the right-hand side that the overall response rate was an impressive 89% of patients who were ROS1 TKI naive, and about 33% in those who were pre-treated. And if we look into that data in a little more detail, you can see from this waterfall plot that the patients that you can see with a response who are in green or in that aqua blue color were patients who had had one or more TKI on previous treatment. So you can see that patients with objective responses in the brain, even despite significant TKI exposure in the past. So what do we know about the side effect profile of this drug? Well, there is an amount of dizziness with it. We haven't got a lot of data on the CNS toxicity. And of course, I would have questions knowing that drugs, TKIs that get into the brain often do have CNS toxicity, thinking of lorlatinib in particular. And so I'd be really interested when we see further publications on this to see exactly what the incidence of significant CNS toxicity is. There were about a third of patients who had dose reductions, but only 7 to 10% of patients discontinued drug, suggesting that actually it is manageable and tolerable. And how does that repotrectinib sit within the other TKIs we have in the ROS1 arena? Well, if you look at that table on the bottom right-hand side, you can see that that 80% intracranial response is really quite substantial, obviously higher than that we see with lorlatinib, ceritinib, and crizotinib, but similar to some of the other newer agents that are in development. So I think watch this space, very interesting and certainly showing some improved efficacy in the brain. So going back to KRAS for a moment, this was a study, Scarlet, which was a single-arm phase 2, which might be of relatively small interest, looking at the combination of chemotherapy plus sotorasib in patients with KRAS G12C. Fairly standard criteria in that patients had to be fit, and they were then treated with sotorasib plus carboplatin pemetrexed, and then went on to maintenance sotorasib and pemetrexed. And in terms of the previous treatment, you can see at that table on the bottom right-hand side that 2 of the 30 patients had previous checkpoint inhibitors, but the vast majority of those patients had not. And when we come to look at the efficacy, there's an impressive overall response rate with combination chemotherapy and sotorasib of nearly 90%, with the median overall survival not reached. The data wasn't mature. And if we look at the toxicity on that bottom left-hand table, the toxicity, mainly myelotoxicity, being driven by the chemotherapy, but of note, there is some elevation of the transaminases. So I guess in terms of where this sits, we've obviously had some problems with combining KRAS inhibitors with chemoimmunotherapy. So this is perhaps giving us more information on patients with KRAS G12C who may not be suitable for immunotherapy. And with those fairly impressive response rates of 90% in that patient group, I think it's not going to be something that changes the treatment for a lot of our patients, but there may be a role for those that don't have the ability to receive a checkpoint inhibitor with KRAS G12C. So moving on from the molecularly driven cancers to standard non-molecularly driven non-small cell lung cancer, there are a number of antibody drug conjugates in development, and there are many studies ongoing. So I thought it would be interesting just to give you a little bit of a snapshot of TROPION-Lung2, which is looking at the combination of Data-DXd plus pembrolizumab with or without chemotherapy. So this is a phase 1 study looking at Data-DXd, and you can see from the cartoon that there's the antibody that is linked to a topo-1 inhibitor, and the cohorts that we're going to be looking at are combining platinum chemotherapy with pembro and Data-DXd, or just the Data-DXd and pembro, what's regarded as doublet therapy. And in terms of the patient characteristics, the one thing that I want to point out here is the majority of patients are treated in the first line. So 58% of those receiving doublet were in the first line, 75% of those receiving triplet were in the first line, with smaller proportions that had been received immunotherapy previously. And when we come on to look at the efficacy, the top left-hand corner is all comers in the study, so including first and second line. And you can see from the first line waterfall plot that most of that effect is being driven by the first line patients because they were much greater in number. But if you look at the spider plot on the bottom left-hand side, it's clear from some of those lines in blue that patients with lower PD-L1 also seem to be getting some durable benefit from the doublet therapy, so without chemotherapy. So I think it's an interesting area. However, I would say that we have relatively immature data as yet, and I think the jury is really still out on the ADCs. In this study, we saw a 20% ILD rate of all grades, and I guess there are some questions about how that is going to combine with other treatments. There was also some grade 3 ocular toxicity that we need to watch out for. So there's several studies ongoing. Many of you may be involved in those. There's no particular biomarker strategy to see where these ADCs are going to fit in the frontline setting. And we really don't know anything about what the addition of the drugs is doing to patients' quality of life. So I think this is going to be an area where we need to see more data. So moving on from there and moving on modalities, I hesitate somewhat to present a radiotherapy study as a mere medical oncologist. However, I think this is a really important study. It was phase 2, the Norwegian study that we've seen previously, but presented at ASCO was the final overall survival. So you can see the study schema on the top there. So concurrent chemoradiotherapy with chemotherapy coming in at the second cycle, and the study comparing standard dose BD radiotherapy 45 gray and 30 fractions to higher dose 60 gray and 40 fractions. And you can see the survival curves at the bottom, and most importantly, that overall survival curve. And you can see an almost doubling of the median overall survival from 22.6 months up to 43.6 months. So that's very impressive data to me for a study that provides a treatment that's somewhat cheaper than most of our medical oncology therapies. However, it was a phase 2 study, and we need to look very carefully at the supporting data. Interestingly, the toxicity was really very similar, with the grade 3 toxicity rate not significantly different in terms of esophagitis and pneumonitis. We didn't see any data on the technical aspects of the radiotherapy in the presentation, and I know that my radiotherapy colleagues would question some aspects of the radiotherapy because we're not seeing any difference in the toxicity. And of course, when we've dose escalated in other settings, there has been greater toxicity associated with that. Of course, in terms of clinical practice, not all centres are currently delivering BD radiotherapy for small cell lung cancer, and there would be an impact of this. So the questions are really around, is a phase 3 study needed to confirm that very impressive improvement in overall survival that was seen? So again, sticking with practical issues in real life, the Japanese presented a very large retrospective study looking at elderly patients in systemic therapy. So elderly, they regarded as patients of 75 years and older, and the systemic therapy was either single agent chemotherapy, doublet chemotherapy, immunotherapy on its own, or combined with chemotherapy. And you can see that there was an impressive age range from 75 to 95. And in terms of the regimens, you can see on the bottom line of that table, 28% of patients receiving checkpoint inhibitor on its own, 34% chemo IO, and then 25 and 12 with double and single agent chemotherapy. And when we come to look on the right-hand side, you can see that the black and the red line, so that's the chemo IO and the immunotherapy arms alone, clearly have much better outcomes, both in terms of progression-free survival and overall survival compared to chemotherapy on its own. So there are really some very important data demonstrating in a very big study of over 1,200 patients that it's feasible for us to deliver standard treatments to our patients, and just because they're elderly, we shouldn't be shying away from doing that. And in particular, when we look at the patients who had high PD-L1, it was helpful to see that the outcomes were no better for combination of chemotherapy and immunotherapy compared to immunotherapy alone. So giving us some reassurance and guidance in a real life setting that it's entirely reasonable to treat these patients who are over the age of 75 with single agent immunotherapy in that setting, as well as having other options if they have lower levels of PD-L1. Importantly, in terms of toxicity, although there were some slight numerical increases in toxicity for those receiving checkpoint inhibitor with chemotherapy, I draw your eyes to the bottom of this table, which shows that the discontinuation rates were actually pretty similar. So about a quarter of the patients in either the checkpoint inhibitor or the combination of chemo IO stopping treatment due to adverse events, and a death rate, again, very similar, about 2%. So in summary, treatment of elderly patients is feasible. There is some slightly increased in toxicity, but discontinuation death rate similar. And so the overall survival benefits that we see with chemotherapy and immunotherapy are deliverable in this older patient age group. So the final curiosity that I will leave you with is tumor treating fields in non-small cell lung cancer. Now, prior to ASCO, I had absolutely no idea what a tumor treating field is, but essentially they are pads that are put on the patient's chest with that then generate an electrical field between those pads that impacts on outcome according to a proposed mechanism of action, which affects cell migration, cell membrane permeability, and the other items that you can see there. And it's important to just let you know that tumor treating fields, this technology is available in the States because the FDA has approved it already in mesothelioma and in glioblastoma. So the study concerned LUNAR was designed some time ago, so in 2016, took a while to recruit. And at that time, of course, the standard of care was different. So it was for patients that had been previously treated with platinum-based chemotherapy, and they were randomized in a one-to-one fashion to receive the investigator's standard choice of treatment, and that was either a checkpoint inhibitor or docetaxel with the tumor treating fields or not. And of course, some of the criticisms of this is that this is not standard of care anymore. However, when we come to look at the outcomes, you can see that there was the study met its primary endpoint, and that was being driven by the outcomes in the patients receiving checkpoint inhibitors. So you can see on the left-hand side, for patients having treatment with checkpoint inhibitor and having the tumor treating fields on their chest wall, that the median overall survival was 10.8 months for patients receiving immunotherapy alone, and increased up to 18.5 months for those with the device in place. And the improvement was not seen in those patients who received docetaxel. So regardless of how unusual this treatment might be, it's clear that there's been demonstrated an 8-month improvement in overall survival. And I think it's fair to say that further study is warranted in these patients receiving immune checkpoint inhibitors, perhaps in another line. So my take-home thoughts, just very briefly, you can see there, I won't go through these one by one because I think we probably want some time for questions.
Yvonne, thank you very much for that superb summary of some interesting bits. So a couple of things that really been buzzing from ASCO and AACR are about the KRAS field, and we've got sotatercept already approved. Hot on its heels is adagrasib. We're waiting for licensing and the UK approvals to come through for that, and there's a whole bunch of other ways of drugging the KRAS MEP kinase axis coming through. I was very interested to see that combination data of chemo with sotatercept. I mean, do you think this is really likely to be a way forward? We just can't combine sotatercept with checkpoint inhibitors. We've seen that from Codebreak 101. The liver tox is just not doable. So is this useful, for example, for your PD-L1 negative patients or your KRAS KEAP1 mutant, STK11 mutant patients, if you know what that is in your genotyping arena, where we think that IO is not really going to offer much, or is this just a niche area for people with bad autoimmunity?
So I think that's a really good question. We don't know the answer to that, but what is clear is that for patients with KRAS G12C, by and large, we are treating those with standard of care, which would be chemotherapy, immunotherapy up front. And of course, the toxicity concern is real. So for me, I don't think this is going to have a role in standard treatment, except perhaps in those patients who cannot have a checkpoint inhibitor at the moment. And I think we don't really know enough about those co-mutations at the moment to say that this would be any better. So I think it's a potential route for therapy for those patients. I think how we get regulatory approval in the UK for a combination such as this is another challenge for us in that particular setting. But I guess that would be an option that I would like to have at some point in the future, but it's probably going to take a very long time.
Indeed, I guess we just wait for a trial. I think there may well be a trial with this combination in the frontline setting. I, for one, was very impressed with the high response rate, but actually the PFS I was a bit underwhelmed by. So I think we just need to see how this pans out in some more detail. Just moving swiftly forward to your small cell study. I mean, that's a massive hazard ratio for overall survival. I know it's only a phase 2 and numbers are relatively small, but if you think about it, right, we've got IO coming through in the limited stage disease. This is a tall hurdle to cross, right, if we can achieve so much with radiation. Tell me, what's the buzz at the Christie about that data, or is there no buzz at all about that data?
So I was very excited about it because those improvements are so big. However, and of course, on the surface of it, it seems to be a relatively easy to deliver win for us. But I have to say, my colleagues at the Christie are less enthusiastic about it. They are very concerned about the fact that we don't have enough. It's a randomized phase 2. The numbers of patients are not huge, and we really don't have the manuscript that was presented from the Lancet earlier on this year. We really don't have a lot of data on technical aspects of radiotherapy. So their feeling is absolutely that we would need to have a randomized phase 3 for that to change practice. And of course, the other slight fly in the ointment is that not all centres carry out BD radiotherapy, and certainly in the States there's very little BD radiotherapy. So I think in terms of where that sits in our likely to change clinical practice, I think that's much more uncertain, and I think it is probably going to need a further study for it to change care pathways in the UK.
Well, one of the things I think we do really well in the UK and actually most of Europe is the delivery of BID radiotherapy for small cell, and for various reasons the US doesn't do that very well. So we await the phase 3 data. And the other big buzz is in the field of ADCs, right? So we're all waiting for the data DXD versus docetaxel randomized phase 3 fully accrued. We're hoping to get some data on that perhaps this year, maybe next year. Let's see what the meetings pan out like. What do you think about combining ADCs with chemo and IO? I mean, to me, I was a bit twitchy about some of the tox that we're starting to see.
I agree, Sanjay. I'm a bit twitchy about some of the tox as well, and it's early days, but I'm not so convinced about the benefits so far. So I'm very, very much on the fence about the ADCs. There's a lot of them out there. There's lots of studies that are presenting. There are some interesting data, but I think we are just going to see how the studies. We're going to need to see how the studies mature.
Great. Well, look, thank you for that overview. We had one question that came in about the sotorasib cost. And does the efficacy justify the cost? And I think the answer is nice. I think it does. So I think, it's cost effective. So there you are. Okay, Yvonne, thanks very much for that great presentation. And now for our final speaker, Riaz Shah, you have the joy of speaking to us about the exciting area of mesothelioma and everything perioperative, where there's lots and lots of data going on. So Riaz, over to you. And folk online, please do keep your questions coming in, and I'll try and pose these to the panel if you do put them into Slido. So Riaz, over to you.
Thank you very much. Good evening, everyone. Fantastic talk so far. So I've got a tough gig here. Yeah, my disclosures. Designed for UK practice, this talk. Now I'm going to talk about mesothelioma and then neoadjuvant SACT. So 2 straight areas. So I'm going to launch straight into mesothelioma. So our first line therapy right now is nivo-ipi based on the Checkmate 743 study. Just remind everyone, this is the updated survival. Look at the brown curve. That's nivo-ipi first line. Look at 12 months, 68% alive. Look at 24 months, 41% alive. Look at 36 months, 23% alive. Just think about that and register that, because it's quite useful looking at some of the stuff I'm going to show you. Now, the median in this study went from 14 to 18 months, median overall survival, 23% crossover rate to immunotherapy in the chemo arm. And if you look at the curves by PD-L1 positive or negative, or by histology epithelioid versus non-epithelioid, just concentrate on the brown curves and look again at those numbers, and you'll see consistently 60-70% of people alive at 12 months, consistently around 40% of people alive roughly at 24 months, and about 20 odd at 36 months. So that's quite interesting, consistent efficacy. So what's the next big thing in mesothelioma? Well, the thing we're all waiting for is just what happened in lung cancer. We had immunotherapy, and then we had all the data on chemoimmunotherapy. So the meso world is on tenterhooks waiting for these trials to report. 3 international randomized studies comparing chemotherapy to chemotherapy plus immunotherapy. And the reason to bring this up is the IND 227 study at the bottom reported its results at ASCO. So this is a Canadian, French, and Italian study, 444 patients to 6 cycles of platinum pemetrexed or 6 cycles to platinum pemetrexed plus pembro, and then maintenance pembro for 2 years. Primary endpoint overall survival. Italy poured patients into this, and the Canadians did very well as well. Fantastic effort. You'll see that 3/4 of the patients had epithelioid disease. Of the non-epithelioids, they were split fairly evenly between biphasic and sarcomatoid. About 60% in both arms were PD-L1 positive, and an equal balance by the EORTC prognostic score. Now, if you look at how many cycles of chemo was given, about half got cis versus carbo. Dose delays were balanced in both arms, dose reductions relatively well balanced, and discontinuations due to AEs reasonably well balanced, slight imbalance with carboplatin, but nothing too much there. Here's the bottom line money shot. This is the overall survival curve presented. You'll see the median goes from 16 months to 17.2 months. The hazard ratio is 0.79. It's positive. Look at the 2-year landmark, 39%, 3-year landmark, 25%. So, okay, it's positive. The curves don't look very far apart, but very, very similar data to what we've seen with Checkmate 743. Can't say that it looks better, can we? If you look at crossover rates in the chemo IO, 17 patients went on to receive subsequent IO, but obviously much higher crossover rates in the non-IO arm. This is the forest plot. Basically, there isn't much to sort of see in this that I think we need to dwell on too much. But if you look at histology, you see what we saw in Checkmate 743. If you look on the right-hand curve, non-epithelioid, you see that chemo does badly. But the immunotherapy, chemo-immunotherapy combo arm is behaving consistently between epithelioid and non-epithelioid if you look at the landmark survival figures at 2 and 3 years. And if you then also look by PD-L1, again, similar landmarks. The curves don't look very far apart at all, but 40-odd% of people alive at 2 years, 20+% of people arrive at 3 years. Response rate consistently higher with the combination of chemo and immunotherapy, and notable that in non-epithelioids on the left, the response rate is very low to chemo alone. So the addition of pembrolizumab to standard chemo did deliver a statistically significant and they claim clinically significant overall survival benefit, PFS benefit, and a response rate benefit, and the treatment was tolerable. The discussant commented on this. If you look at the table at the top, this is comparing response rate, PFS, and OS figures in all arms between Checkmate 743 and this study, and you'll see they're not very different at all. Notable that when you look on the bottom 2 tables, the only outcome that's distinctly statistically positive with non-overlapping confidence intervals is Checkmate 743 PD-L1 positive cis-pem versus nivo-ipi, and that's the bottom right-hand corner. So The conclusion by the discussant: is this a new regimen that improves outcomes? Yes, it does. Is it meaningful? Well, it's a month. Were the patients appropriate? Were the controls appropriate? Yes, I think so. And where does this fit? Well, it's a option, isn't it? It's a potential new first-line option. But this is really disappointing, I think, from the meso community. We were hoping to see stellar data, better than 743. What we're seeing is not much different. Really does put a bit of a downer on the whole flavor of everything. The DREAMER-3 study is still going on. It's had its control arm changed to nivo-ipi and now is purely restricted to epithelioid patients. Beat Meso, I'm thankful to say, completed accrual a while ago, and we await the results. So that's that. Moving to a completely different study. Peter Slozarek from Barts conducted this excellent study called Atomic Meso, presented at AACR. This is a phase 2-3 study looking at arginine deprivation in non-epithelioid mesothelioma, feeding on from the ADAM phase 2 study. And this is a randomized study. So patients were randomized 1-to-1 to cis-PEM for up to 6 cycles, plus the subcutaneous injection of ADI-PEG20 versus placebo, obviously including chemotherapy. Primary endpoint of this study was overall survival. It was well balanced by stage. You'll see about 50% of the patients were sarcomatoid and about 50% biphasic. This is the overall outcome. So it's a positive study. The median went from 7.7 to 9.3 months. Interesting. But obviously the issue with this is that immunotherapy is really the thing that we're all excited about in non-epithelioid mesothelioma. Slightly more toxicity, particularly hematological, in the investigational arm. And so this is a potential option. It would reasonably safe, reasonably well tolerated. Interesting, but not sure this will take off. The last meso study I want to go to is a phase 1 study. So this is a YAP inhibitor. Timothy Yap, our ex-colleague from London, who managed to exceed terminal velocity, escape of the gravitational pull of our domain and settle in the MD Anderson, where he's been thriving, presented this fantastic study. This is all to do with the hippo pathway, which is quite complicated. But if you look at the table, the graph on the left, that outlines some of the characters in the hippo system. It's a very complex system, but a large number of mesothelioma patients have inactivation of NF2, which is a suppressor of the hippo pathway. So if that gets inactivated, the hippo pathway is overactive, and the end effector right at the bottom is this transcription factor called YAP. And what happens with YAP is, to get activated, it needs to undergo a process called palmitylation with another protein called TEAD, and then it becomes active and transcriptionally changes the function of the cancer cell. So what this drug is, VT3989, is it's a chemical, an inhibitor that gets into the palmitate pocket, and therefore inhibiting palmitylation, and therefore inhibiting the transcriptional activity of YAP. Oh God, I've lost my scrolling ability. Here we go. So this is a very early phase study, dose escalation, phase 2. Let's cut to the chase. We don't need to spend too much time on this. This is the waterfall plot. Multiple patients with multiple tumor sites. The purple ones are all meso patients. And you can see a sizable number of meso patients are responding to this. And you can see that many of these patients have NF2 mutations, but not everyone. So it's not a black and white story. Duration of treatment seems reasonable. So a phase 1 study, very early, but interesting. Something new, something potentially molecularly targetable for our meso patients. And perhaps if this develops into a bigger, more widely accepted treatment, we might be genotyping meso patients routinely. I'm going to move swiftly, complete night's move, and talk about neoadjuvant chemoimmunotherapy in non-driver, non-small cell lung cancer. So we've been doing surgery for a long time. We know that if you add adjuvant chemo after surgery, you get a benefit. And we also know that adjuvant immunotherapy, IMpower010, can help. That's atezolizumab, approved in our high PD-L1 patients by the MHRA and EMA, but in the FDA approved in anything above 1%. Always be conscious that the staging has moved from the 7th to the 8th edition with a slight change in the staging. So 1B in the 8th edition is not eligible. It's stage 2A, 2B, and 3A, with some 3Bs actually, but that's irrelevant. What we're talking about here is neoadjuvant chemoimmunotherapy. So you're all aware of Checkmate 816, the stuff that has come online in the NHS in the last few months, 3 cycles of neoadjuvant chemo IO followed by surgery and nothing else. Another alternative is to use neoadjuvant chemo IO surgery and then adjuvant immunotherapy. Now, Checkmate 816, you all know the study design, 3 cycles of chemo IO or chemo, then surgery within 6 weeks. Fantastic benefit, massive path-CR rate, massive major pathological response rate, all subgroups benefit, 17% path-CR rate, even in PD-L1 negative patients. And notable that this had a third arm that no one talks about, where they just gave nivo-ipi, an exploratory arm, and the path-CR rate in that arm was 20%. I'll come on to the relevance of that a bit later. But here we've got the event-free survival curves, the overall survival curves, and the collapse in distant metastases as a result of the delivery of only 3 cycles of neoadjuvant chemo IO. So several studies have reported at AACR and ASCO, and I'm just going to quickly whiz through some of them. So Aegean is durvalumab, so chemo plus durvalumab or just chemo placebo, 4 cycles, surgery, and then a year of durvalumab if you're in the IO arm. And this study basically predominantly stage 3A patients, PD-L1 expression a third. Patients were allowed to have carbo or cisplatin. Most of the patients underwent surgery, but about 20% didn't. It's worth remembering that. A portion of patients won't ever get onto surgery. Most of these patients had R0 resections, and the number of patients that start post-surgical immunotherapy is a fraction of the people that go in initially. And many patients discontinue for whatever reason. The path-CR rate is 17%. The MPR rate is 33%. All patients benefit across histology, perhaps never smokers, not so much. PD-L1 expression, PD-L1 negative patients, less benefit, but about 9% of these patients had a path-CR who were PD-L1 negative. That's the event-free survival. Look at 24 months, 63% event-free survival. And so this is another study that looks very similar to Checkmate 816. And then at ASCO, we had 2 studies, Keynote 671, MSD, pembrolizumab, basically almost identical study, chemo pembro or chemo placebo with a year of pembro. This was 4 cycles, no patients, all patients could go in, including a small number of EGFR ALK patients. And then the NeoTorch study is a study from the Far East using a PD-1 inhibitor called toripalimab, and very similar design, except 3 cycles of chemo given before surgery, 1 cycle after surgery, and then a year of your immunotherapy. What do these studies all show? Well, the path-CR rates are very similar, 24%, 18%, 24%, 17%. Not much difference there. The major pathological response on all these studies looks very similar. The event-free survival looks very similar. Hazard ratios 0.58, 0.68, 0.68, 0.4. The event-free survival landmark at 24 months is 63% or 62% in almost all the studies. Extraordinarily similar results. Very immature survival data, lots of sensor points. Don't want to overinterpret this, but a strong suggestion that this will translate into a bona fide survival benefit. So does having that year of immunotherapy after your neoadjuvant treatment make any benefit? We don't know. It hasn't been prospectively tested. We need to prospectively test that. But very interesting comment from one of the discussants said, look at the Checkmate 816 curves in patients who had or did not have a path-CR. And if you look at the curve on the left, you will see that patients that had no path-CR who had immunotherapy, the green lower curve and the gray lower curve are very, very similar. But if you look at patients that didn't have a path-CR in Keynote 671 and NeoTorch, you see that the curves seem to separate. Maybe, tantalizingly, that might be the effect of the post-operative immunotherapy. Who knows? There was an update on Checkmate 816 focusing on the patients, the 20% of patients who didn't get surgery, who we're very concerned about. And what we see is many of these patients did get subsequent therapy, ranging from radiotherapy and systemic therapy. And you can see on the right, the patients who don't end up having surgery do seem to have quite bad outcomes, as you could imagine. And the last thing I want to leave with you is this. So this is East Energy, a Japanese study where they said, let's get rid of the chemo altogether. Let's just see what immunotherapy can do. They used pembrolizumab with ramucirumab, so antivascular plus checkpoint inhibitor. So patients had 2 cycles of this, went straight on to surgery, and fascinating, MPR rate 50%, PathCR rate 25%, really good waterfall plot there. So overall message, neoadjuvant chemo IO is the standard for operable disease. There is a gray area between what's operable and inoperable, not really for this thing, but we do need better definition. We need to prospectively validate post-neoadjuvant therapies. And we also need to look at which patients need de-escalation or intensification. So the patients who have a PathCR, do they actually need anything else? Can we just leave them alone? The patients without PathCR, can we improve their outcomes by intensifying treatment? And can we deliver a chemo-free option for some patients? And that's it.
Oriel, thank you very much for that superb overview. Let's take a few questions for what you've talked about. So one of the questions that's come in is in the sort of 816 setting, preoperative chemo IO. We know that we're restricted to the EGFR wild-type ALK wild-type group. What happens when you find an exon 20 insertion or a RET or a ROS? Are they still eligible for preoperative chemo IO?
Well, many of the patients are, many of the genotypes are actually eligible. If you go and look at the blue tech form for Checkmate 816, it doesn't exclude many actionable mutations. My personal view is that the group of patients that you would think wouldn't respond to immunotherapy, I probably wouldn't offer this to, right? So what I mean by that is my sort of the cohort who are lifelong never smokers. So I don't think personally this is the right treatment for an ALK, an EGFR, a ROS1, a HER2 insertion. But outside of that, these things haven't been prospectively validated in those molecular subtypes.
Yeah, I tend to agree with you, actually, to be honest with you. I think that's very correct. So I'm going to ask you about the perioperative setting now, just focusing on that. We now have 816 preoperative only, several trials, preoperative, postoperative. The first of those reported is Aegean. We also have NeoTorch and Keynote 671. So undoubtedly Aegean and Keynote 671 will be coming to the UK at some point soon, presumably before ASCO next year in routine clinical practice, right? So many centers in the UK are still struggling with implementation of 816. What do we do, right? Is who needs preoperative and who should just have adjuvant? And I guess who should have both?
Well, my personal view is this is the biggest thing to happen in lung cancer since immunotherapy came along, right? This is massive. And I think the benefit of neoadjuvant chemo IO in the operable patients is so great, it's borderline clinically negligent not to offer it. And I do think there will be court cases in the future where patients who relapse feel that they've been hard done by not being offered the treatment. So we need to be very careful about what we document. We need to be very careful about exactly what's written in MDM outcomes. If patients aren't for this treatment, it needs to be very clear cut as to why that it was considered and it was felt inappropriate for reasons A, B, C, and D, right? So I just think the data is overwhelming. I mean, PathCR, major PathCR, the event-free survival, the very strong suggestion that this is going to translate into an overall survival benefit, it's astonishing. And then the lower pneumonectomy rate, the collapse in relapse with distant metastases. This is only 3 cycles of neoadjuvant chemoimmunotherapy. I find it extraordinary that such a short period of treatment could deliver such massive impacts on patient outcomes. And the thing to remember is any strategy that involves giving a patient something after surgery is going to have a drop-off. Patients get infections, they get post-operative physiological change that makes them ineligible for subsequent systemic anti-cancer treatment. The drop-off is massive. When patients come to us untreated, naive, we can treat a large number of them.
I think that's right. I think the outcomes of PATHC are just, spectacular. We've never seen anything like it. So we really must try and offer that to our patients if at all possible. I'm going to just focus in lastly on the world of meso. I know you're passionate about this. So what are we going to do? What are we going to offer our patients? Nivo-IPI, IND-227, or ADI-PEG? Which is the winner? Who gets what? Or does everybody still get Nivo-IPI? What are your thoughts?
That's really interesting. That's really interesting. So I think ADI-PEG in non-epithelioid is going to have a tricky run because immunotherapy is so amazing for these patients. You literally see patients who are in a terrible state of health, but still PS1, of course, who improve dramatically when exposed to these treatments. I think the reality is if you give chemo IO, you have to deal with the toxicities of chemo and the toxicities of IO. If you just give IO, you only have to deal with the toxicities of IO. So to my mind, Checkmate 743 Nivo-IPI, I agree it's a little bit hotter than just single agent immunotherapy. I'm not going to disagree with that. But I do think I've got less problems on my desk in terms of micromanaging a patient through that treatment than I have if I'm introducing chemo as well. And I mean that in terms of the whole service. Patients are coming in, they're having treatment, they're going home.
Yeah.
We've got really good established support systems for people on immunotherapy. So I'm struggling to see how that's going to become an option.
Yeah, great. Thank you for your views. And Riaz, I'd just like to thank you for your presentation. In the interest of time, we'll just wrap up this session. I'd like to very much thank our 3 speakers for flying straight in and straight onto their laptops, for getting the slides hot off the press and presenting the data to you. And thank you very much for working hard over the weekend to make these presentations available to BTOG members. Yvonne, Riaz and Tom, thank you very much for everything that you do for BTOG and the BTOG community. It really is absolutely great. Our next online event is going to be a World Lung update, World Lung in an hour, at some point in September, to be confirmed. World Lung, let me tell you, is promising to be another amazing congress. There's going to be practice-changing data presented there. So we do hope to update all of you on the data in due course. And let me tell you, ESMO 2023 is going to be spectacular. There is going to be undoubtedly practice-changing data presented there. So that we'll be doing another update in October 2023. So do make sure that you keep those dates free when they are announced. Finally, our next in-person event for BTOG is our lung cancer screening update. If you're interested in screening and you're part of the screening community, do register. We have our in-person update all day on Friday, the 6th of October, based in London. And our newest event is going to occur in December. It's going to be an update for any early lung cancer oncologist. So a new oncologist treating lung cancer within 5 years of taking up a consultant post. We want to discuss all the issues around who you choose, which therapy to, and you'll be able to hear from the experts, and you'll find out more of this in due course. Thank you very much for your attention. Thank you very much for your questions. I do hope you found it useful, and do continue to support us in everything that we do for all of you in terms of our outputs. And with that, have a great evening. Thank you very much.